Hi everyone, and welcome to our module on respiratory acid-base disorders. So let's review the four classes of acid-base disorders. There are the respiratory alkalosis and acidosis problems. Then there are the metabolic alkalosis problems, which I discuss in their own module. And finally, the metabolic acidosis problems, which also have their own module. In this module, we'll talk about these two disorders, and they are far and away the simplest acid-base disorders because they have a very short list of causes. So we'll start with the respiratory alkaloses, and these occur when the PCO2 falls and the pH rises to be more than 7.45. And remember, these problems are easy to understand if you know the acid-base equilibrium equation, which I've drawn down here. Anytime you have an imbalance in this equation, the body will try to correct it. So if you get a low CO2 level, this equation will go this way by the body in order to try and correct that low CO2. As a result of more activity in this direction, you will lower the amount of H+, and that means that you will get a high pH, and that's how you develop a respiratory alkalosis. So all respiratory alkalosis disorders are caused by hyperventilation, and the most common reason people hyperventilate is when they're in pain. So pain in surgical patients after an operation, or pain from a hip fracture or anything like this, can raise the ventilatory rate and lower the CO2 level, and this can cause a respiratory alkalosis. Two other unusual causes of respiratory alkalosis that you should know for your boards are high altitude exposure and aspirin overdose. So let's talk about those now. So when people ascend to very high altitudes, like when mountain climbers climb Mount Everest, for example, the atmospheric pressure is very low, and this means that there will be low PO2. So the body senses that hypoxia and triggers hyperventilation. This will lower the PCO2 level and cause a respiratory alkalosis. The pH will rise. So early on, when you ascend to high altitude, you can have a respiratory alkalosis. Now, about a day or two later, the kidneys will begin to excrete bicarb, and the pH will start to fall back towards normal, and then the ventilation rate will decrease as patients become accustomed to this. So later on, after you've been exposed to high altitude for a while, you may not see the respiratory alkalosis. That's why we say it occurs in early high altitude exposure. And one thing you should know is that acetazolamide, which is a carbonic anhydrase inhibitor, is sometimes given to people who ascend to high altitudes to augment that excretion of bicarbonate by the kidneys. So aspirin overdose is a classic board question, and you should make sure you're familiar with the acid-base consequences of taking an overdose of aspirin. So aspirin overdose essentially causes two acid-base disorders. Shortly after patients ingest an overdose, they get a respiratory alkalosis, and this is because the salicylates stimulate the medulla directly, and that leads to hyperventilation. Recall that your respiratory control center is in the medulla. Several hours after ingestion, there's an anion gap metabolic acidosis that occurs. And this happens because the salicylates block lipolysis and they uncouple oxidative phosphorylation, and this is going to inhibit the citric acid cycle, which you know from your biochemistry. As a result of this inhibition, there'll be accumulation of pyruvate and lactate and keto acids, and all these things cause an anion gap metabolic acidosis. So what does all this mean for the lab values when you're evaluating the patient? Well, the pH is variable because it's a mixed disorder. So the patient may be alkalotic early on and acidotic later, and they can even have a normal pH from a mixture of the two disorders. The CO2 is usually low due to hyperventilation, and the bicarb usually gets low due to acidosis. And if the patient has acidosis, when you go to check the CO2 with Winner's formula, you will find that Winner's formula predicts a CO2 that's higher than the actual CO2. Or another way to look at it is the CO2 is lower than expected for compensation because of the mixed disorder. So this is easiest to understand if we do a sample case. Imagine a patient with aspirin overdose has a pH of 7.3, a PCO2 of 20, and a bicarb of 14. Well, the pH is low, so we know it's an acidosis, and the bicarbonate is low, so we know it's a metabolic acidosis. Now we see that the PCO2 is low, and that's what we expect in a metabolic acidosis from respiratory compensation, but we need to check that that reduction in CO2 is appropriate, and the way we check is through Winner's formula. So Winner's formula says that the expected PCO2 is 1.5 times the bicarb plus 8 plus or minus 2. So if you plug in the numbers here, you see that the predicted CO2 is 29 plus or minus 2. So we should have a CO2 level anywhere from 27 to 31. But our CO2 is 20. It's lower than expected. And that's because the patient is hyperventilating from the aspirin overdose. They are blowing off more CO2 than would be expected for the acidosis. This means we have a concomitant respiratory alkalosis. Okay, now let's talk about respiratory acidosis disorders, and these occur when the PCO2 gets high and the pH falls below 7.35. So let's go back to our equilibrium equation here. If the CO2 gets high, the body will try to correct for that by driving the equation in this direction to bring the CO2 back down. When it drives the equation in this direction, it will increase the level of H plus atoms, and that will lead to an acidosis. So respiratory acidosis is caused by hypoventilation. So what type of patients hypoventilate? Well, the easiest ones to understand are patients who have lung disease. So patients with COPD or pneumonia or asthma or a CHF exacerbation, they can all hypoventilate, and this means their CO2 level can rise because they aren't able to blow off that carbon dioxide, and they can get a respiratory acidosis. Another classic cause of a respiratory acidosis is a patient on narcotics. So narcotics suppress the respiratory drive. So a patient in the hospital, for example, with extensive cancer pain who's taking a lot of narcotics can start to hypoventilate and become acidotic. And then finally, the other group of patients who often get a respiratory acidosis are people who have muscle weakness in their respiratory system. So patients with neuromuscular diseases like myasthenia gravis or ALS or Guillain-Barré or muscular dystrophy, all of these patients, as the disease progresses, can hypoventilate and begin to retain carbon dioxide, and that leads to a respiratory acidosis. Let me just finish this module by mentioning hypercapnia, which is an increased level of carbon dioxide. If you have a CO2 level that gets very high, this can affect the central nervous system. Most patients with an acute CO2 level increase are agitated, but some also have a depressed consciousness. We call this CO2 narcosis. But the bottom line that you need to know clinically as a physician is that any change in mental status in a patient with respiratory disease should prompt consideration that the CO2 level may be getting high. You need to check an arterial blood gas, and if the CO2 level is high, these patients often need ventilation to bring the CO2 level down before they develop dangerous depression of their central nervous system. So make sure you're aware of that effect of high CO2 level on your patients. And that concludes our module on respiratory acid-base disorders.